Welcome back for another Sheriff of Sodium video. Today, I feel that my constabulary duties compel me to discuss one of the most deeply unpopular components of our modern healthcare system, which is health insurance prior authorization. I mean, doctors hate it. So if you need a little dopamine hit, all you really need to do is go out there and trash prior authorization on the social media platform of your choice, and you can bask in the warm glow of sympathy from your peers and colleagues. Or if for some reason you'd rather be the heel, then by all means go contrarian on this issue and take the insurer's side and assert that prior authorization is a necessary cost control and really it's done for your own good. Either way, you will quickly find yourself immersed in a sea of misinformed replies that show that people really don't understand what's actually going on here. So today, the fact police are going to roll up on prior authorization and help you see through the smoke screens and understand what's really going on in this system. Let's start here by squaring away this fact. Insurance companies don't really make money by denying claims. Even though, if you observe someone in the wild engagement farming this issue, that's exactly the comment that they want you to make. They want you to say that prior authorization is just a way for greedy insurers to deny more claims, because then they get to keep more premium dollars for themselves. The thing is, that's not exactly how prior authorization functions or how insurers make money. I mean, at least not anymore. So if you'll allow me, let me take you on a whirlwind tour through the history of prior authorization so that you can understand how and why this system evolved. If you go back 150 years, of course, there was no prior authorization because there was no health insurance. Back in them days, if you wanted care, you paid your doctor directly. You put cash on the barrelhead, or maybe you paid with some produce or goods in barter. And this economy worked because overall healthcare costs were low. Medical care was something that took place in the home. Doctors were solo practitioners making house calls, and their fees were modest. There wasn't any real concept of healthcare coverage because there really wasn't much that medicine could do for you that was worth covering. For most people, the biggest risk of getting sick was that you'd lose wages because you weren't able to work. So actually, some of the first baby steps toward having a health insurance market like what we have today were actually efforts that organized a disability insurance of sorts. This system started to change with the advent of the hospital. From the 1870s to the 1930s, the number of hospital beds in the United States grew exponentially. Now, this was also an era of substantial improvements in the scientific practice of medicine. So these hospitals transformed from being just almshouses or pest houses or places where poor people went to die into places where real medical care was provided. But that kind of care isn't cheap. I mean, you could rapidly bankrupt yourself by paying out of pocket for hospital care, especially because the hospital's bills were due at the very time that you weren't able to work. So when they got sick, many patients couldn't afford to pay the hospital, and many others avoided going to the hospital in the first place, and all of that hurt the hospital's bottom line. So in 1929, the Baylor Hospital in Dallas came up with a solution: health insurance. This would allow patients to collectively share the financial risk and hospitals to reap the financial reward. Under the first health insurance plan, Texas school teachers could pay 50 cents a month into the hospital, and in return, if they got sick, they would receive up to 21 days of hospital care per year at Baylor. The Baylor plan was a big success. Ultimately, it served as the prototype for Blue Cross, the first prepaid hospital insurance. And soon, other companies weren't far behind. By 1958, 75% of Americans had some type of health insurance. And by 1965, with the passage of the Medicare Act, we really entered the modern era of health insurance in the United States. The problem was the cost. As more patients got insurance, more patients received health care. And in a fee-for-service environment, doctors and hospitals had an incentive to provide as much care as possible. And so soon, healthcare costs were rising rapidly. Now, this pinched the insurers, and they didn't want premiums to rise too rapidly because they worried that some patients would start to opt out of the insurance system and just go back to self-pay. And of course, the patients who would be most likely to opt out would be ones who were healthy and didn't anticipate needing much medical care, which would leave the insurers with a high-risk pool of customers who might be willing to pay a lot for health insurance, but that was because they were pretty sure that they were going to need it. So to prevent this and maintain their profit margin, insurers had to find a way of limiting their costs. So, starting with the Blue Cross plans in the 1960s and soon extending to other commercial insurers and Medicaid and Medicare, instead of insurers just paying whatever claim got sent their way, the companies began examining claims for medical necessity. They started by just looking at prolonged hospitalizations, and they found that by using a reasonable standard, some 10 to 30% of them appeared to be unnecessary. And so they started denying coverage for those. But this put doctors and hospitals in a bind because by the time that this utilization review had occurred, they'd already been providing services to that insured patient, and now they found out they weren't going to get paid for it. So there was, at least initially, a desire from both sides to have some kind of prospective way of agreeing upon whether something was going to get covered or not. And so, beginning with pre-certification for hospitalizations and progressing into prior authorization for diagnostic tests and medications, we entered the world that we now live in, where playing mother may I with insurance companies is a key component of medical practice. These prior authorization programs spread because they worked. Early data showed that for every dollar that an insurance company spent on prior authorization and utilization management, they could expect to save maybe $10 or even more. So prior authorization proliferated, but it was largely tolerated and regarded as being an annoying administrative issue or a problem just for the back office staff. But it didn't take too long for opinion to turn, because every year, as healthcare costs continued to increase, it became harder and harder for insurers to trim the fat. By the late 1990s, as the managed care era wound down, there was increasing public backlash against insurance companies. There was even congressional scrutiny over insurance companies' cost-cutting measures that seemed like they were limiting necessary care, as well as the frequent rate hikes that looked like profiteering. One troubling thing was that insurance companies spent very different amounts on claims. I mean, some insurers, like the nonprofit Blue Cross, they spent up to 90 cents out of every dollar that they took in on premiums paying for claims for their beneficiaries. But many for-profit companies spent much less, maybe only 70 cents out of every dollar they took in on premiums. There was growing sentiment among regulators and the general public that health insurers were denying claims just to keep their profit margins high, and that they were using the red tape of prior authorization systems as one way of doing it. Enter the Affordable Care Act. Among many other things, the ACA limited the amount of profit that insurers could take by requiring that they spend 80 to 85% of the dollars they take in on premiums on people's health care. This is something called the medical loss ratio, and even though it's been the law of the land for over 15 years now, there's still a lot of pundits online who remain ignorant of it, or at least want to present themselves that way for likes, because they're still out there posturing as though denying claims is how insurance companies make their money. It isn't. I mean, at least not anymore. In the pre-ACA era, an insurance company could, I suppose, if they wanted, deny all the claims they got and just keep all the premiums they took in as profit. Now, that wouldn't be an advisable long-term business strategy, but I don't know that it would have been legally impermissible. But under the ACA, if an insurance company pays out less than the 80 to 85% they're required to pay out as benefits, they would have to issue a refund for that amount to their policyholders. So depending on the type of the plan, the insurance company only gets to keep 15 to 20% of the money that they take in. And that 15 or 20%, it has to cover their operating costs and leave enough profit to satisfy their shareholders and pay out those big executive bonuses. If an insurance company wants to win under the ACA's medical loss ratio rules, they got to play a more sophisticated game, and prior authorization is a big piece of it. So that brings me to the next fact that we need to get straight. I mean, sure, there's some stuff you got to deny, but delaying coverage really has big benefits for insurers. Now, before I explain this, I'm going to give you a little story time. This story comes from the early days, right after the passage of the Affordable Care Act, back when yours truly was still a junior deputy nephrology fellow. And back in those olden times, I would go to work and round in the hospital and see patients in the clinic, and after having participated in these meaningful patient care activities, I would arrive back at my desk at the end of the day with a little spring in my step. And then I would look at the pile of papers on my desk, and I would see how the rest of my day was going to go. Now, usually the height of the pile told you what you were going to be in for, but sometimes it was a little bit misleading because there might be stuff in there that was relatively easy to deal with. I mean, medication refills or faxed orders about this or that had to be signed. But the worst thing to discover as I worked through that pile was the prior authorization requests. So I'd get to one of those and my shoulders would slump, and I'd stare at the phone for a good long second before finally dialing the number for the insurance company and starting to work through their labyrinth of a phone tree to try to get to a real person who would nice me up and listen to me explain why this request was indeed medically necessary. And of course, this was not an easy thing to do. I'd have to sit there listening to that stupid hold music, that and all of this, it gave me a lot of time to think. And mainly, what I would think about was what a waste of time all this was, because I knew whatever it was that we had prescribed was medically justified. I mean, I could see the value in putting up a prior authorization hurdle for stuff that patients didn't really need, or if there was a cheaper alternative. But the kind of thing that I was fighting for back at that time, it was stuff for like Epogen for kids that had chronic kidney disease. There was not really an effective alternative. And no pediatric nephrologist was just going to, let their dialysis patients become highly sensitized and transfusion dependent because they had to do a little paperwork. Of course we were going to fight. And to be honest, I took a certain amount of pride in having a near 100% approval rate. And so as I sat there, I would get angrier and angrier, and I would think about all this in my head, and I would wonder, how much does it cost to make this system that's keeping me on hold? How much is the company paying the representative who is eventually going to talk to me and nice me up with customer service speak and then approve the request? Wouldn't it be worth their while, just not to do this, not to put up this particular barrier for this particular thing in this particular patient population? I knew about the ACA and the medical loss ratio, so wouldn't getting rid of unnecessary prior authorization requests reduce their overhead and ultimately save them money? But actually, it wouldn't. So if you don't see the flaws in my youthful thinking, let's think together about the universe of outcomes that might occur when an insurer makes a prior authorization request. And let's assume that the request is for something that's completely justified and medically necessary. And what we'll see is that although a few different things are possible, most of them are beneficial to the insurance company. The first possibility is the one that I imagined when I was waiting on hold, that the claim would get paid. After all, the request was medically necessary and the doctor is going to fight for it, so the insurance company is going to have to pay the claim. And that's not really a good thing for the insurer, right? That should have a negative expected value, because now they're out the money they had to pay for the claim, plus whatever they spent by activating their stupid prior authorization apparatus to fight against something that they should have known from the first place they were going to have to pay for. But there are other possibilities. Another one is that maybe, for whatever reason, the doctor doesn't fight for it and the claim disappears. Maybe the doctor or their staff's just too busy and they don't have the time to fight, or I don't know, maybe their fax machine is broken, or the doctor's on vacation and it somehow falls through the cracks. Now, some types of prior authorization requests are highly likely to be approved. In fact, in pediatric hematology oncology, the overall approval rate for many things is around 98.5%. But notice that even then, it's not 100%. So because a certain non-zero number of claims will disappear, depending on what your overhead costs for prior authorization are, maybe this could end up being a winning outcome for the insurer. A third possibility is that the patient disappears. Maybe they get better. Maybe they die. Maybe they just switch insurers. After all, 15 or 20% of people change their insurance in a given year, usually because they change jobs. So if you're the insurance company, you don't have to say no. If you just say not yet, again, a non-zero amount of these requests for expensive services or medications are going to disappear because the patient, in one way or another, is going to move on. So out of the three possibilities we've seen so far, it looks like maybe we've got two that have a likely positive expected value for the insurance company. So if you were an executive, depending on how you assess the probabilities and payoffs, that alone might be enough to justify requiring prior authorization, even for services that are medically necessary. But if you're not convinced, and I don't want you to be too hasty, let me sweeten the deal a bit, because there are other, much more significant benefits to putting up these barriers. One benefit doesn't really have anything to do with anything that happens now. It has to do with what happens in the future. I framed this battle on the phone as a one-off, but in reality, it's not. The hospitals and prescribers that want you to pay claims today, they are largely the same ones who are going to want your company to pay other claims tomorrow. So, by introducing a little bit of friction, you can condition their future behavior. Even if you approve the thing today, if you create just enough of a hassle, you might not have to approve quite so many of them in the future. You wouldn't have to spend a dime to do it because, on the margins, in those gray areas, the prescriber may think, let's give the prednisone a little longer before I go to a biologic. Or, I don't know, maybe we don't need the MRI just yet. Maybe we can do another round of PT first. Now, as you already know, the point is not to deny claims. If you're the insurance company, your ultimate goal is to make your claims more predictable so that you can hit the sweet spot of that medical loss ratio year after year. Now, to do that, you need to have your actuaries be able to accurately predict your costs, and they can do that a lot better if you have a low variance data set. So if you're playing the long game and you condition your prescribers with frequent prior authorization requests, you select for more low variance prescribing behavior. Another benefit of these prior authorization requests, even the ones you have to approve, is that they generate data, and data are powerful. As a prescriber, you may win, but to win, you're going to have to explain why the treatment is medically necessary. And when you do that, over time, you're generating for the insurer a vast data set that they can use to shift their approval criteria. You can war game this with a computer. What would our claims look like if we required 6 weeks of conservative therapy instead of 4 before approving this lumbar MRI? You can also use the prior authorization data to build high-quality data set about providers. You can figure out who's the most likely to order expensive imaging or procedures. And I don't know, maybe that's something you ought to take into consideration when you're negotiating your next contract with them or when you're deciding who's in or out of your network. That information may be very valuable to you. Again, in an era where computing power is cheap, there's an incredible power in data. And by harnessing it, you can make your claims more predictable, which is, again, the end goal. But even if you get hit with something unpredictable, something your actuaries misjudged, there's still another benefit to delaying care, which is that you get to see the costs before they occur. Before you even have to open up your wallet, you know what bill is coming, so you can plan ahead. You can adjust your rates. You can tinker with your approval criteria for future claims. Or you can even just prepare your shareholders because you know what you're going to have to pay before it actually impacts your bottom line. But even if none of that mattered, even if you don't mine or utilize your data in any sort of sensible way, and even if you were dealing with a pile of claims that you knew with certainty that 100% of them were medically necessary and were going to have to get paid, there would still be a benefit to simply delaying the payment of those claims by putting up a prior authorization hurdle. And that's because time is money. Because when the prior authorization gets approved and the service is rendered and the bill is due, it's not like old man Cigna just cracks open his wallet like Ebenezer Scrooge and forks over a few bills. The money that patients pay in premiums, it's not just sitting around in a safe or stuffed under the mattress at the United Healthcare's executive's house. All that money is invested, and it's earning interest. And the longer you let it sit there, the more interest it earns. This is what's called, in the insurance industry, the float. And you might think it's trivial because, how much money do you think you could make in interest over the 2 weeks that a prior authorization claim is pending? You wouldn't notice a difference in your checking account, right? But when you're talking about the amount of money that's passing through these corporations, it adds up. Let me give you some real numbers. In 2021, Anthem took in around $130 billion in premiums. And according to their SEC filing, they had investment income of $1.1 billion. In other words, even though they got a rate of return of less than 1%, they still ended up with an extra $1 billion, which amounted to nearly 20% of their total profit for that year. Time is money, so extending that time pays off. And before I close, I need to police one last sector on this topic. and that is this: AI will not fix prior authorization. That is actually the impetus for this video, because I've grown so incredibly weary of seeing all the glib talk about how AI is going to fix this. I mean, usually that talk is coming from someone who's trying to sell you an AI solution to streamline your practice's prior authorization processes. And don't get me wrong, this is a real problem. According to an AMA survey, the average doctor is juggling 43 prior authorization requests per week, and it takes on average 12 staff hours per week to manage that, which of course is time and money that could better be spent on almost anything else. But what do you think? I mean, do you think that if your practice buys an AI system to manage prior authorization requests, that you're going to bring the insurance companies to their knees? Or do you think it's possible that maybe they'll just get their own AI system so they can deny and delay your AI-generated prior auth requests even faster? I mean, sure, if everybody gets AI, it may change the way the system looks. I mean, we could get to a new equilibrium where things seem to happen faster, or where big hospital systems that can afford a big shiny AI bot to fight on their side in the prior authorization bot wars, they can gain a relative advantage over smaller physician groups that have to fight with their bare hands. But if you've paid attention during this episode and you understand why we have prior authorization in the first place and how it benefits insurance companies, it should be crystal clear to you that implementing AI in this space is not going to change anything. The problem with prior authorization is not that it's being done by human beings with fax machines, but it could be done with chatbots. That's not the problem. Automation may make things look smoother from the outside, but the incentives in the system do not change. As long as insurers profit from controlling timing and utilization and predictability, AI is only going to make those control points more efficient. If you really want to do something about prior authorization, these gimmicky solutions are not going to work. And I'm talking here not only about the doctorpreneurs who are trying to sell you their AI system, but also the gimmicky legislative proposals that address some limited aspect of the prior authorization system. I mean, those things are just squeezing a balloon. You can shift the bottleneck, but the underlying business logic remains the same. Healthcare expenses are rising, and insurers have an incentive for them to rise, because then the size of their 15 to 20% premium slice comes out of a bigger pie. If you really want to fix prior authorization, you better have the appetite to change the incentives. I mean, maybe you make delays unprofitable by taxing them. Maybe you penalize harmful delays. I mean, maybe you consider, again, the fee-for-service system, and think about payment models that give doctors and hospitals better incentives to constrain costs. Or maybe you do something else. And we all have different vantage points and value systems, so in this debate, we may see different solutions. But we should all have the same set of facts. So I hope this video has armed you with some, because it's dangerous out there. Stay safe, and thanks for listening.